Hi, welcome to our final presentation. We decided to do our final presentation on non-Hodgkin's lymphoma with rituximab as our targeted therapy. I'm Haley Siebold.
I'm Cassidy Carteret.
I'm Ashton Labarge.
And I'm Christine Maxey.
So, non-Hodgkin's lymphoma originates in the lymphatic system, typically in lymph nodes or in bone marrow. It also affects white blood cells called lymphocytes, which tend to grow abnormally and then form growths throughout the body. There are many different types of tumors that we went through. Our main one is diffuse large B-cell lymphoma. Like I said, it's the main subtype for non-Hodgkin's lymphoma, and it composed of 40% of all cases. Usually develops due to abnormal B lymphocytes. We also have follicular lymphoma and Malt lymphoma, which are both low grade. We have Burkitt lymphoma, which is high grade, skin lymphoma, mantle cell lymphoma, angioimmunoblastic T cell lymphoma, and Richter syndrome. And those last three are all rare. So non-Hodgkin's lymphoma can be developed through hereditary, familial, or sporadic reasons. It can also be caused by mutations in the DNA of white blood cells, like I said before, also called lymphocytes, as well as also being caused by viral or bacterial infections. For example, I gave HIV, Epstein-Barr infection, Heliobacter pylori, etc. are all examples. Regarding mutations, there's not a lot of information of lymphoma regarding tumor suppressor genes because they are unique types of cancer. However, generally, if a mutation occurs in one's DNA, it can cause the tumor suppressor gene to turn off and as a result cause cancer through excessive cell proliferation. I did find one example using PTEN where if it's deficient in particular, it has been associated with advanced disease, resistance to chemotherapies, and poor cell survival, which likely has a role in lymphoid malignancies. Regarding the hallmarks of this cancer, non-Hodgkin's lymphoma acquires sustaining proliferative signaling, evading growth suppressors, resisting cell death, enabling replicative immortality, inducing angiogenesis, as well as activating invasion and metastasis.
Moving on to the cancer epidemiology for this part of the presentation, we have the current incidence and mortality statistics. So in 2019, the CDC published recent statistics about the incidence of 75,575 cases, and then they reported 20,270 mortality cases. And this non-Hodgkin lymphoma occurs in men more than women, and you have a higher chance of developing non-Hodgkin lymphoma with increasing age. And then to the right, you can see a picture of the United States where the number of new cases in 2019 spread throughout. And you can also see in orange the number of cancer deaths in the United States in 2019. And the darker the color gets, the more prevalent the cases are. Okay, and we can also see the number of incident cases for non-Hodgkin's lymphoma in 2019 based in comparison by race and ethnicity. And you can see on the left that incident cases were more significant in Caucasians than in any other race. And on the right, you can see that the mortality rates were the same. It was more significant in Caucasians than in any other race. And then if we compare incidence and mortality over time, we can see that in 1992, the rate of incidence was 18.6 and the mortality rate was 8.2. And in 2019, the rate of incidence was 18.3 and the mortality rate was 5.4. If we compare the two, we can see that the rate of incidence decreased only by a small amount. The mortality rate was seen significantly reduced due to new treatments and screening. Okay. And a risk factor that affects non-Hodgkin's lymphoma is autoimmune diseases. So if you have autoimmune diseases, it increases your chances of developing non-Hodgkin's lymphoma. And basically, the autoimmune diseases are when the immune system attacks the body's own tissues. This could be multiple sclerosis, rheumatoid arthritis. And this disease is basically can mistakenly attack lymphocytes, and it can cause lymphocytes to grow and divide more often than usual, and it increases the risk of them developing into lymphoma cells. So if you have an autoimmune disease, you have an increase of 7.6 in developing non-Hodgkin's lymphoma. And there was a study done regarding this risk factor, and it showed that the severity of the disease further increases the risk of developing NHL, and the researchers of the study suggest that in order to catch non-Hodgkin's lymphoma early on, that early and more frequent screening should be done to catch non-Hodgkin's lymphoma in patients who have pre-existing autoimmune diseases.
So moving on to the cancer epidemiology, our chosen intervention for treating non-Hodgkin's lymphoma is a drug called rituximab. This drug can either be used alone or in combination with chemotherapy. When it's used alone, it can be used for low-grade NHL that has been relapsed or is in a refractory, or for low-grade NHL that has not progressed after a first-line therapy, whether that is chemotherapy or a different therapy. It can also be used as a maintenance therapy, both with or without chemotherapy. And then with chemotherapy in children, it is often used. We'll go over it a little bit later in this presentation in more depth, but as a general overview, almost all non-Hodgkin's lymphoma cells express a surface protein called CD20. It's found on all B cells, and rituximab targets these. In the picture, you can see that with chemotherapy, there was 70% chance of patients being alive, but that was a 10% increase when having chemotherapy and rituximab, and similar trends followed that. When looking at, as the disease got worse, or responses lasting after 14 months versus like 38 months. So the side effects of rituximab is the same as many drugs. It can be very common or very rare. It's usually administered intravenously with a drip or as an injection under the skin in a couple of different ways. Some common side effects, meaning about 10% or more of people get these experience these side effects, include increased risk of getting infections, bruising and bleeding, swelling of body parts, headache, fever, vomiting. Rare side effects include changing in blood clotting and other various blood disorders, such as hemolytic anemia, where red blood cells are destroyed faster than they can be created, or aplastic anemia, where the bone marrow stops making blood cells altogether. It can also be, it has also been linked to tumor lysis syndrome, where changes in levels of hormones in your body cause a breakdown of all tumor cells. Holes in stomach and bowels have also been related to this medication, as well as the possibility of kidney failure. rituximab has shown to increase life expectancy from anywhere from 3 months to 5 years. However, the cost can be up to $16,000 more in comparison to some other treatments. Patients less than 60 on rituximab showed a reduction in hospitalization. For the cost effectiveness ratio, there's a $61,984 per cancer case, and this cost effectiveness was seen to decrease with age. But overall, this drug has shown to be a useful treatment in NHL patients, but it generally has a higher price in terms of money.
NHL subtypes are categorized by the characteristics of the lymphoma cells, including appearance, presence of proteins on the surface, and genetic features. The two subtypes are aggressive and indolent lymphomas, aggressive being fast-moving and accounting for 60% of all cases, indolent accounting for 40% and being slow-moving, slow-growing. The overall 5-year relative survival rate for people with NHL is 73%. Prognostic factors that can make this number vary is patient age, stage of lymphoma, whether the cancer is in the organs outside of the lymphatic system, performance status of the person, and blood levels of lactate dehydrogenase. Patients with aggressive T or NK cell lymphomas usually have a worse prognosis. Patients with low-grade lymphomas have increased survival of 6 to 10 years. However, they can have transformation into high-grade lymphomas. It is staged into 4 levels, and that is dependent on localization, subtype, and where in the body is involved. And NHL is quick to metastasize and most often spreads to liver, bone marrow, and lungs. The treatment for aggressive lymphomas in most cases is treated with R-CHOP, which is a combination of rituximab, Cytoxan, hydroxydoxorubicin, Oncovin, and prednisone. It can be supplemented with radiation in event of a tumor. One of the most common first-line methods is rituximab combined with chemo. Treatment for indolent lymphomas range from the watch and wait approach to aggressive therapy, depending on the subtype, prognostic factors, stage of disease, age, and other medical conditions. Mechanisms of resistance that NHL displays are overexpression of drug transporters, mutations in TP53, and overexpression of MAPK and AKT cascades. Rituximab is one of the most effective single-agent treatments for NHL and works well combined with chemotherapy. It has a response rate of 45 to 60%, even in pre-treated patients. In aggressive types, the response rate is about 30%. It's typically administered intravenously, ropic line, portacath, or central line. If there is no central line present, it is administered through subcutaneous injection or an IV cannula. It's usually administered as cycles so the body can recover after receiving the medication in between. It is important to note that every cycle depends on what type of cancer and the reaction to the previous cycle before it. The initial cycle will be a slow drip into the bloodstream for prevention of an allergic reaction. All following cycles are determinant of the cycles before it, but they will be quicker. Rituximab by itself as monotherapy, 84% of patients experience an adverse event similar to other chemo treatments within the first 30 days. 97% of events were of a 1 to 2 intensity, but repeated administration of rituximab can substantially prolong duration of remission without affecting tolerability. Rituximab combined with chemotherapy, the response rate is almost 100% for indolent lymphomas. Infusion-related reactions occurred in 19% of patients with a 1 to 2 intensity in the initial infusion. Grade 3 or 4 events were observed at 9%, but all symptoms disappeared after the infusion was slowed down or stopped. Rituximab is a monoclonal antibody that depletes B cells from circulation. It binds to the CD20 antigen surface marker expressed on pre-B and mature B cells. The immune system finds the marked cells easier and kills them. The mechanisms of action that are thought to be are complement-mediated lysis, antibody-dependent cell-mediated cytotoxicity, and induction of apoptosis after binding to the CD20 antigen on the cell surface. Apoptosis occurs due to the B cell's function reduction or reduction in plasma cell production. Rituximab has an excellent safety profile, and overdosage has not been reported in clinical trials. Serum concentrations are taken, but they do change drastically throughout the therapy. CBC blood levels are taken before and post-treatment, but no therapeutic index has been defined for the specific drug in regards to blood levels. B cell depletion is monitored, as well as liver and kidney levels. I did find a study of phase 1 trials of 2 doses of rituximab, 500 milligrams per meter squared and 375 milligrams per meter squared for 4 weeks each. Both showed clinical responses with no dose-limiting toxicity. The weekly 375 milligram per meter squared dose given for 4 weeks, that one was selected for further phase 2 evaluation and is currently the standard single agent dose and schedule. Despite advanced outcomes in the first-line treatment of rituximab, up to 50% of patients do relapse, especially high-risk patients based on prognosis, but with further longitudinal studies, that number can be improved.
This is all of our references and the end of our presentation. We really hope you enjoyed, and thank you for watching.